So neuropathic pain is typically pain being experienced in someone with nerve damage. It's a very personal experience. Pain is not visible. And this is different from, say, inflammatory pain, where the pain comes from a damaged tissue. And so if you have arthritis or you cut your hand or your finger, you experience pain. There's local tissue damage, and that's called inflammatory pain. Whereas neuropathic pain does not need to have an external visible area of damage. The nerve is damaged, and therefore it sends a different signal to the brain, which is then processed as pain. There are multiple causes of neuropathic pain. Any process that can intrinsically damage the nerve can lead to neuropathic pain. Of course, the commonest cause world over would be diabetes, but many other conditions that can have a nerve involvement can also lead to neuropathic pain. On its own, it's the nerve symptoms which, when they are more severe, are experienced or converted by the body as a pain experience. So what could start off as neuropathic symptoms, numbness and tingling, when it's present at a very high level, becomes pain. Neuropathic pain can affect any part of the body, and it depends on the condition that is driving it. So in diabetes, typically the nerve damage is in the lower part of the limbs. The distal extremities are most commonly affected, and therefore you experience pain in the feet, going up the legs, and some people also experience pain in the hands. But in some other conditions, like if you had shingles, you can get pain over the area that you get shingles, and that is a type of neuropathic pain. Other people can get nerve pain in certain regions of the face, and something like trigeminal neuralgia, and people with back problems, when there is compression of the nerve roots, can also experience a type of neuropathic pain. Now, typically, neuropathic pain is managed with multiple interventions, not just one. I would choose a specific condition here to discuss management, which would be diabetic neuropathic pain. And we often, the first thing to do is make sure that the pain is because of a specific diagnosis. So you would like to confirm whether it's diabetic neuropathic pain or not. And you do end up doing tests to make sure that's what it is. Once confirmed, it depends on the pain score. We often ask our patients to rate what pain they experience, what level of pain they experience, on a scale of, say, 0 to 10, 0 being no pain at all and 10 being the worst pain. And we also ask them to rate on a scale of 0 to 10 what their peak pain is. So you can have background pain, which is severe, but you can still have spikes on top of that. So we often ask our patients to tell us their background pain and their peak pain. And if your pain score is less than sort of 4 or below, we often try and find interventions. For example, making sure your diabetes is well controlled is very important in the management of diabetic neuropathic pain. We make sure for the foot, whether if your foot shape is correct, make sure you have the right insoles, you wear a correct footwear, which may all contribute to lowering the pain experience. But if your pain is more severe than that, it impacts on your functioning, that you don't sleep well at night, that during the daytime you're irritable, and broadly have tried measures that could improve the quality of pain, but with no relief. We can often treat it with pharmacological interventions, and these may be externally applied, like an ointment or a spray, or more often in our clinics, we often use the drugs such as duloxetine and pregabalin or gabapentin in different doses. The choice depends on certain aspects, like if you have depression, duloxetine is known to help with that, so one would think of using it as first line. Pregabalin has anxiolytic function, and in some studies has been also shown to improve the sleep component. So we would tailor the initial agent according to an individual's specific needs. There is no perfect first starting agent, and recent studies have suggested that any of the three first line choices that are recommended by NICE, that's amitriptyline, pregabalin, or duloxetine, are equally efficacious. So the initial choice of a neuropathic pain agent, particularly for diabetes, is dependent on many factors which your doctor will assess. Of course, for those experiencing severe pain, one may need to also add in other options, at least temporarily, and these may involve the use of mild forms of codeine or occasionally morphine type medications. We discourage the use of long-term morphine and try and use multiple other modalities. And one of the things I do in my practice for complex pain is seek the help of psychologists who I have found to be invaluable in supporting the individual, but also an early access to a pain clinic and to see a pain specialist that is extremely helpful. And these are specialists who have a background in pain medicine, but also in anesthesia, and can often offer the higher end of pain support, and are quite distinctly different to physicians who are involved in the early diagnosis of neuropathic pain, the treatment of secondary risk factors, and making sure that all other adjustable variables are fully optimized. Both components are important. You start with the first, assess the response, and then you can move on to the second level if you need to. The word curable is very subjective. Neuropathic pain, in particular in this context, diabetic neuropathic pain, is definitely controllable. The response is very individual, and often you would require to find the right agent, sometimes more than one type of neuropathic pain agent to achieve this. In certain specific conditions, the neuropathic pain recedes after a degree of time. There are conditions where if you improve your diabetes control too quickly, you get what is called treatment-induced neuropathy of diabetes, with severe acute pain that starts rather quickly, rather than the typical diabetic neuropathic pain that starts slowly and builds momentum over months. And such pains can often recede and completely disappear with good diabetes control. So diabetes control and achieving neuropathic pain elimination is very important. Many of our patients experience major improvements in their pain scores to an extent that even if they experience a subtle amount or a degree of pain, they don't find it intruding in their day-to-day life. Some pains, of course, like I mentioned earlier, can completely burn out, but the experience is individual and cannot be guaranteed at the beginning of treatment.